We had just finished building this house and moved in, and I had been having what I thought were just GI issues, and so I had pushed my doctor that I need to have a colonoscopy and was very shocked at the diagnosis.
I remember the phone call. It was a Friday morning. It was Beth on the other end saying, "I've got colon cancer." You're in shock and disbelief, and she's only 31. This is something that they don't even check for until you're in your 50s.
Everything else fades away, and nothing else is important other than making sure you're still here for your family and for your kids.
When I initially met Beth, she was very anxious. She was afraid of what the future holds. She had a small kid. She was planning for another kid. Colon cancer in the young behaves differently. They're often very aggressive. After we do surgery and cut the cancer out, we often treat them with chemotherapy-based treatments for an average of 6 months duration.
Chemo was hard from my very first session. The neuropathy was the hardest thing. You can't drink anything cold, you can't touch anything. It was the middle of winter, so going outside was really difficult. I actually wasn't sure if I'd be able to finish all of it because of the adverse side effects.
We don't know if all patients require 6 months of treatment, but the challenge is we don't have good tools to decide which patients require full 6 months, which patients we could stop sooner than that. The standard tools that we use for monitoring, such as the CEA in the blood or imaging, such as CAT scans, they're good to a certain extent, but there has to be a sufficient amount of tumor activity for it to pick up. We needed something more precise, and that's when I decided to utilize Signatera. Looking at a blood test where we are able to isolate DNA fragments from the tumor cells helps us figure out if it may be safe to stop or de-escalate chemotherapy. When we did the Signatera testing at 4 months of chemotherapy, it did come back negative.
As soon as it came back negative, that's when I really felt like, okay, I really am done with chemo. Maybe we can start trying to have a baby sooner.
We had to make a choice with the best and most accurate information we had, and we felt that Signatera provided that for us to, at that time, make the decision to try to conceive and try to expand our family.
Once we found out we were pregnant, we talked about how are we going to monitor for cancer recurrence. Dr. Kasi said, we're not going to be able to do CTs, but we have your Signatera test that is going to pick up any remaining cancer if it occurs while you're pregnant. Signatera did give me the peace of mind while I was pregnant because there was no other indicator for me that I'm healthy, this baby's going to be healthy.
So far, we have not seen any evidence of recurrence of cancer. Hopefully, the cancer never comes back and she's cured.
Signatera gave me the freedom to just feel that everything is going to be okay. I am healthy again, and we can actually move on, just enjoying being together.
Welcome to our second Signatera webinar on ctDNA testing and molecular residual disease in early-stage colorectal cancer, where we'll explore the important role of ctDNA in detecting a colorectal cancer recurrence. We'll have an in-depth discussion and overview of the Signatera ctDNA test and explore how it can identify cancer recurrence. This webinar is sponsored with an educational grant from Natera and is intended for the information of patients, caregivers, healthcare professionals in conjunction with the launch of the test in Canada by LifeLabs. My name is Barry Stein, and I'm the President and CEO of Colorectal Cancer Canada. I'm also a survivor of early age onset of metastatic colon cancer that was diagnosed in 1995, and I hope to bring some personal perspectives in the question period today. I'm delighted to have the opportunity to moderate this webinar, and I'm confident that you will also find it informative and filled with valuable information. It is a great pleasure to have with us today two distinguished speakers, Dr. Minetta Liu, who is a medical oncologist and the Chief Medical Officer of Oncology at Natera. Prior to her transition to industry, Dr. Liu served as professor and research chair in the Department of Oncology at the Mayo Clinic in Rochester, Minnesota. In her 10 years at the Mayo Clinic, she held a secondary appointment in the Department of Laboratory Medicine and Pathology and served as co-leader of the Genomics in Action strategic priority for the Center of Individualized Medicine and established the first precision oncology clinic. Dr. Michael Raphael is a medical oncologist at the Odette Cancer Center at Sunnybrook Health Sciences Center. His practice is dedicated to the care of patients with gastrointestinal cancers. He is also an assistant professor at the University of Toronto and head of the GI Medical Oncology Clinical Trials Program and medical oncology lead for the Hepatic Arterial Infusion Program at Sunnybrook. Today, Dr. Liu will discuss important information about the Signatera test, including what the test is comprised of, how it works, what the validation studies have been done to date, and how the test can be applied to monitor early-stage colorectal cancer. And Dr. Raphael will discuss some individual case studies and provide his perspective as a medical oncologist treating colorectal cancer patients in Canada. Following their presentations, there'll be an opportunity for our speakers to respond to any questions that you may have. If there is insufficient time to answer your questions, our speakers will be pleased to respond to your questions by writing in the days following the webinar. I'm now so pleased to introduce Dr. Minetta Liu.
Thanks very much, Barry. So I'm going to give an overview of Signatera's molecular residual disease test in colorectal cancer. These are my financial disclosures. I did a fair amount of research and advising when I was in academic practice, and then I joined Natera in June of 2022. Natera has a strong history of product innovations and has really been focused in the cell-free DNA technology space. This started in 2009 with Women's Health. We didn't foray into oncology until 2017, but only 2 years later, we have a launch for a product in colorectal cancer. Oncology at Natera includes several products. We have over 10 million tests that have been processed to date and 400 more patents issued or pending. We are focused on residual disease detection and the applications in cancer monitoring for early stage disease. ctDNA testing or circulating tumor DNA testing is what we're going to focus on today. Our product is known as Signatera. The reason we developed an assay looking at circulating tumor DNA is because there are limitations in measuring disease burden using current tools. We have imaging, but we can't on imaging detect micrometastatic disease, and it also then exposes patients to radiation. We have routine clinical pathologic characteristics. These are risk features that from the tumor itself or from a patient, but these can also be subjective and don't always correlate with outcomes, meaning survival related to cancer diagnoses. From the blood, we do have serum-based protein biomarkers. Unfortunately, they have low sensitivity and specificity, meaning that they can be hard to detect, not always seen when someone has cancer. And if they are detected, doesn't always mean that cancer is there or progressing. There's been an evolution of tumor surveillance over time, dating from 1896 with the X-ray machine, progressing through a variety of imaging modalities, ultrasound, CT scans, MRI, PET-CT scans, and now circulating tumor DNA. And as you look at this over time, you can see that we're getting more refined in our ability to detect cancer. So 10 to the 9 cancer cells with the routine X-ray, 10 to the 7 cancer cells with CT scans, and now 10 to the 5 cancer cells, at least with current methodologies for circulating tumor DNA detection. And as those technologies improve, that detection will improve as well. So what is circulating tumor DNA? And what are we talking about when we talk about MRD? Cancer cells release circulating tumor DNA into the bloodstream. Either the cells are dying or they're actively pushing DNA and other materials into the blood. ctDNA is a powerful tool that can then be measured to assess the absence or presence of what we call molecular residual disease, meaning detecting that DNA in the bloodstream, even if we might not see evidence of the cancer on an imaging study or on a physical exam. ctDNA is a dynamic real-time biomarker with a normal half-life of less than 1 hour. And although a blood draw is not non-invasive, it is minimally invasive and does afford us an opportunity to repeat test the blood to see if there are changes in the tumor, unlike having to do biopsies, which certainly are associated with more discomfort and cost for patients. Signatera is a minimal residual disease test or molecular residual disease test. It is a personalized tumor-informed assay which distinguishes itself from other blood-based assays for cancer care. This requires a sample of tumor tissue that's collected as part of routine care, and that tissue is sequenced to identify a unique signature of mutations. Again, this is personalized for the tumor in the individual patient. From that unique signature of tumor mutations, we will custom design a blood test for every patient, targeting the top 16 mutations found in the tumor. So 16 unique features of the tumor then get put into this one single blood test. It's like creating a footprint for that tumor or fingerprint. That blood test then serves as a personalized assay that can be used to test patients' blood for the presence of circulating tumor DNA. And again, this can be done repeatedly over the course of time. This is an example of a Signatera report. So we'll report the presence and absence of ctDNA, positive, negative, but we also can measure circulating tumor DNA as mean tumor molecules per mil of plasma. So that's a quantitation or a way of actually measuring not just is it there or not, but what's happening to it over time. Because of the wealth of data that we've created across many solid tumors, in the United States, Medicare covers testing for colorectal cancer, breast cancer, muscle-invasive bladder cancer, as well as all solid tumors during treatment with immune checkpoint inhibitors or immunotherapy. We can use ctDNA or MRD testing to support treatment decisions. One urgent question is there any cancer left in the body after surgery? If you do a scan, you don't see anything. It's called postoperative residual disease detection. We can use Signatera after surgery, perhaps to evaluate the need for adjuvant therapy. Adjuvant therapy or medications that are given after surgery are really targeting that microscopic disease that we can't see. A second important question is there cancer lurking? So all treatment is done, but did you do what you said you were going to do? Serial monitoring can be performed to rule in or exclude the potential for a recurrence. And with a blood test like Signatera, we can detect recurrences earlier while the tumor may either be resectable or certainly curable. And is the treatment working? Treatment response monitoring can be facilitated by using Signatera to assess tumor response to immunotherapy quantitatively. We're here to focus on colorectal cancer as part of Colon Cancer Awareness Month. Recurrence rates in stage 2 colorectal cancer and stage 3 colorectal cancer are illustrated here. Surgery alone is very effective in both stage 2 and 3 colorectal cancer, 80%, 50% cured by surgery alone, respectively. But not everybody is cured by surgery, and chemotherapy is administered, but not everybody benefits from chemotherapy. And chemotherapy isn't necessary in everyone. So can we use a test to help reduce the number of patients who receive chemotherapy by targeting those patients who truly need chemotherapy? And that's really the purpose of MRD testing right after surgery. A variety of studies have been done, so I'm just going to summarize some of the data from these key clinical trials. This is from the Galaxy clinical trial, which is part of Circulate Japan. This is an observational study where patients undergo surgery for a new diagnosis of colorectal cancer and then have blood drawn and are observed over the course of time. What you're looking at here are survival curves. We're looking at disease-free survival and the percent of disease-free survival over time. The straighter the line in terms of it being horizontal, like the line at the top, better, basically. Looking on your left, you're looking at all stages, stage 2, 3, and resectable stage 4, represented in the Galaxy trial in what we call the MRD window, which is a blood draw about 4 weeks after surgery. And ctDNA positive patients, which are represented in the green line or the top line, did much better than those patients who had ctDNA detected. The same is true if you look at all stages within the surveillance window, which means that surgery is completed, no adjuvant chemotherapy is administered, or a patient has surgery and chemotherapy is administered, all is said and done, and we're basically watching and waiting. Patients who have ctDNA not detected or who are ctDNA negative, again, did much better in terms of disease-free survival than those patients who had ctDNA that was detected. In fact, circulating tumor DNA or ctDNA by Signatera proved to be the strongest prognostic factor for colorectal cancer in the Galaxy trial. So this is looking at disease-free survival based on ctDNA status at that MRD window, meaning after surgery. Here we define that window as 2 to 10 weeks after surgery. The 24-month disease-free survival was 3.8% in the MRD positive group, versus 89.1% in the MRD negative group. That is a very highly statistically significant difference. If you look on the right-hand side, this is looking at multiple variables or characteristics of tumor or of patient that can be associated ultimately with outcomes. And as you can see at the top, ctDNA at the MRD window, if it's positive, is all the way to the right. And showing that it is the strongest prognostic factor for disease-free survival and poorer disease-free survival. Again, we're talking about stages 2 and 3 colorectal cancer where adjuvant chemotherapy is administered or can be administered. And can ctDNA detection help us to define which patients should or should not receive chemotherapy, because we can predict benefit based on that testing. So looking at patients who are ctDNA positive, so all of these patients had detection of circulating tumor DNA right after surgery. Those patients did benefit from chemotherapy. That's represented again in that top line for disease-free survival compared to those patients who did not receive chemotherapy. So patients who are MRD positive post-surgery demonstrated a significant benefit from adjuvant chemotherapy. That's what ACT stands for. This is in contrast to patients who were ctDNA negative, where testing did not reveal molecular or minimal residual disease after surgery. Again, these are stages 2 and 3 patients with colorectal cancer, and those two lines are on top of each other. They all did well. Patients who were MRD negative post-surgery demonstrated no significant benefit from adjuvant chemotherapy. Importantly, we can look at the blood test over time. So it's not just looking at one result right after surgery. So comparing ctDNA detected after surgery versus clear at 6 months, you can see it disappear. That's called clearance. So ctDNA clearance at 6 months, again, showed that patients had much improved disease-free survival over those who did not clear. And importantly, again, as you're checking over the course of time, sometimes the result will go away and come back. Does that mean the same if it goes away at any point in time? Does the fact that it comes back and becomes detected again mean something? And that's what you see on the right-hand side. The top line is sustained clearance, that green line. The blue line showing inferior disease-free survival of those patients who did not clear. And somewhere in the middle is transient clearance, where again, it cleared, it went away, but it did come back again. The BESPOKE trial is an observational trial that was supported by Natera, completely different patient population. This was performed in the United States. The results, when we did similar analyses to Galaxy, are virtually identical. We did have the ability to look at some additional data, and this was recently reported, and we were looking at rates of oligometastasis-directed therapy. So in colorectal cancer, what can happen is that new metastases can develop or recur, but these are very limited, very few lesions where maybe without systemic or medical therapy, you can do site-directed therapy, for example, just removing and targeting that lesion or managing it another way. So 101 patients patients in BESPOKE did have a recurrence. Oligometastatic directed therapy was possible in 40 patients. And they actually, half of those patients did well with only oligometastatic directed therapy. And those types of therapy are broken down here in terms of localized treatments. One patient received chemotherapy with radiation. And very importantly, what happens to the patient as you're doing this testing? Are we doing harm, perhaps, by giving results to patients where you might not see something on a scan, or you might see something on a scan? So there have been concerns, understandably, about the potential for fear, anxiety, mood disturbances around the test itself. So as part of BESPOKE, we did patient-reported outcomes and questionnaires. We received 1,130 responses from 413 patients. 73% of patients reported that their test results reduced anxiety about cancer recurrence. 87% felt they were receiving the right treatment after receiving results, giving them confidence in what they were doing. 92% would continue to use ctDNA testing to monitor cancer, and 96% valued the additional information received from ctDNA test results. One question is, if you find ctDNA after definitive treatment is completed, you're in that surveillance phase, then what happens if you find a signal in the blood, but the scans don't show anything? So we are now working with many groups to help generate that evidence. It's called Treating on Molecular Recurrence. So the INTERCEPT study is being done at MD Anderson Cancer Center in Houston, Texas. This is looking at patients with stage 2 colorectal cancer, stage 3 colorectal cancer, and resectable stage 4 colorectal cancer, where patients have completed their definitive therapy, are in surveillance, and have ctDNA drawn predominantly during the course of surveillance. If there is a signal in the blood, ctDNA by Signatera is detected or positive, and scans are performed and there's no evidence of disease, they're offered the opportunity to participate in any of a number of MRD clinical trials. Initially, there was this is an ongoing effort, but as was reported at ASCO, a big conference last year, 184 patients, or 61% of the patients who had enrolled, were ctDNA positive during surveillance. About half of those patients had clean scans, and about half of those patients enrolled in clinical trials, showing the power of this sort of a platform. And those clinical trials are being performed and will read out to help us to prove if there is benefit on treating on molecular recurrence. So in conclusion, how can Signatera help patient care? Again, there are a number of questions. Does Signatera reliably predict for cancer recurrence? Yes, we have a wealth of data to support its prognostic ability. Does Signatera reliably predict treatment outcomes? Yes. As we saw, patients who are MRD positive will benefit from adjuvant chemotherapy, whereas patients who are MRD negative do not benefit from chemotherapy. Can clinicians use early changes in Signatera to predict long-term outcomes? Yes, we've seen that early ctDNA clearance on adjuvant chemotherapy correlates with disease-free survival. Is Signatera useful in oligometastatic stage 4 colorectal cancer? Yes, in helping to direct patients toward oligometastatic directed therapy. How do patients view MRD testing? Is it causing increased anxiety? Gratefully, in the BESPOKE study, we saw that no significant difference in anxiety was seen between Signatera positive and negative patients. Signatera turned positive during surveillance. Now, what do we do? About 50% of the time, you will find radiographic or radiologic evidence of disease, but if the scans are clear, one could consider intensifying surveillance and or enrolling those patients into clinical trials. It's been a pleasure talking to you today. I just want to give a word about Signatera and its availability in Canada. It became available as a send-out private pay test through Life Labs Genetics on February 1st of last year. Payment and generation of a test requisition form are completed directly through the Life Labs website. They provide the kits. They'll help get the tissue sample that's required to develop the test. We'll send all of the samples to Natera. The cost is $4,500 for the initial test and $2,000 for the subsequent blood tests. The blood test results are available in 4 to 6 weeks for the first blood test because we need the time to develop the test first. Once that test is locked down, it takes 1 to 2 weeks for subsequent tests. It's now my pleasure to introduce Dr. Michael Raphael, who's going to give his clinical insights about ctDNA testing. Thanks again.
It is my sincere pleasure to be with you all today on this webinar put on by Colorectal Cancer Canada, and thank you to Barry and Minetta for those really insightful introductions and talks. I am a medical oncologist at the Odette Cancer Center, and I'm here today to give you a bit of clinical perspective about how using the Signatera tumor-informed circulating tumor DNA can help bring some personalized cancer care to patients and families. So I have no conflicts of interest or financial disclosures to make. And so my objectives over the next 15 minutes or so are to review the potential roles of tumor-informed circulating tumor DNA to help personalize care for patients with early and late-stage colorectal cancer, to present some case examples where circulating tumor DNA using Signatera was very helpful for myself and my patients, and ask you to advocate for reduced cost and broader access to this very important tool that I think all patients in Canada who are undergoing treatment for colorectal cancer should have access to. I'll give you some background and context. Now, Minetta gave you some really detailed information on the Signatera assay and some of the studies that have been done to date. I'm going to give you a little bit of background from the clinical context when I'm seeing a patient in clinic, why this test can be particularly helpful. So starting off with localized colon cancer, talking about stage 2 and stage 3 disease, surgery is the mainstay of treatment for stage 2 and stage 3 colon cancer. Following surgery, adjuvant chemotherapy may be recommended to try to kill off any residual cancer cells to reduce the chance of cancer recurrence. But even in 2024, we have no 100% accurate way to predict if the patient sitting in front of us will recur after their operation. As you just heard, even with CT scans, PET scans, MRIs, if they don't show visible cancer, it unfortunately does not mean that there is no residual cancer at all. Cancerous cells may be present beneath the limit of modern imaging threshold detection. You have to remember that each cancer cell by itself is tiny. They're about 20 micrometers in diameter. By the time a lesion is 0.5 centimeters, about the limit of where we can start to detect things on CT scans, that lesion already has about 10 million cancer cells. So if there's 1,000 or 10,000 or even 100,000 cancer cells hiding in the body, they will have not reached that critical mass to allow a lesion to be seen on imaging. Because we cannot be certain if residual cancer exists after surgery, we are now using several tools to help us make a recommendation about whether to pursue adjuvant chemotherapy or not. Some of these tools might include looking at risk factors, using risk calculators, or looking at historical outcomes of similar patients with a similar type of cancer pathology. So for example, in stage 2 disease, we'll look at the patient's pathology and ask, does it show any features which should make this a high-risk stage 2 colon cancer? Those would be things like, is this a T4 tumor? Were there less than 12 lymph nodes sampled? Was it high grade? Was it poorly differentiated? We'll also look at clinical features of the case. Did the patient present with a perforated tumor? Did the patient present with an obstructing tumor? And by looking at the presence or absence of these risk factors, we'll try to get a sense of how likely it is that this cancer could come back in the future, and how likely it is that this patient may benefit from the use of adjuvant chemotherapy. As an extension of these risk factors, now these risk calculators that are widely available, there are many different sites that will offer this. This particular one is from Memorial Sloan Kettering Cancer Center. You can go onto their website, you can plug in all the information from the previous slide, the T stage of the tumor, the N stage of the tumor, the grade of the tumor, and it will generate an expected overall survival after surgery. And this can help in the discussion between a patient and their oncologist about whether or not it makes sense to pursue adjuvant chemotherapy. When we move into the stage 3 setting, Most oncologists would recommend adjuvant chemotherapy for most patients with stage 3 colorectal cancer because unfortunately the chance of recurrence is quite high. In order to determine how much benefit a patient might get from adjuvant chemotherapy and how much benefit they may get from each of the respective components of the treatment, what we do is we look at you as the patient, your pathology, and then we look back in time to see how did similar types of patients with similar pathologies do when they received adjuvant chemotherapy. And so this graph here is an example I use in clinic all the time for patients with stage 3 cancer. This comes from a large international collaboration, which was called the IDEA trial, which was 6 independently run clinical trials around the world that mostly included patients with stage 3 colorectal cancer. At the bottom of the screen, you can see the distribution of subgroups within the stage 3 diagnosis. So the T stands for T stage, so that's the tumor depth. The N stands for end stage, which refers to the number of lymph nodes that were positive. On the left-hand side of the screen, you can see low T and low N. On the right-hand side of the screen, you see high T and high N. What you can see in the shaded bars with the diagonal lines is the chance of being alive and well without cancer following surgery alone. Understandably, that chance is highest when you're starting off with a low T and low N stage. In the dark gray bar, you can see the added benefit of taking the fluoropyrimidine component of your chemotherapy. That's either that capecitabine pill or the fluorouracil bottle. In the white bar, there's the added benefit of the first 3 months of the oxaliplatin IV chemotherapy. And in the black bar, there's the added benefit of the next 3 months of oxaliplatin IV chemotherapy. So the treatment given between 3 and 6 months. And so using figures like this, we try to have discussions with patients and their families about how much the relative benefits of chemotherapy might be given their T and N stage. But what you can recognize is that these tools tell you about the average risk of recurrence for someone who shares your risk factors. These tools tell you nothing about your actual risk of recurrence and whether chemotherapy will benefit you or not. Moreover, our current staging systems have significant limitations, and I'll point your attention again to these 2 figures. One would reasonably assume that if you have a lower stage cancer, a stage 2 cancer, the chance of the cancer coming back would be less than if you had a higher stage cancer, a stage 3 cancer. After all, a stage 3 cancer had cancer cells which were able to sneak out in the lymph nodes. But as you can see on this figure, that is not always true. Starting on the left-hand side of the screen, we can see that for someone with a stage 2 cancer, that's a T4BN0, their chance of survival after surgery alone is about 71%. And you can see that on the right-hand side of the screen, that patients with certain subgroups of stage 3 cancer actually have better overall survival compared to patients with a stage 2 cancer. So a T1N1A has 80%, T2N1A has 77%, and so on, all better than the 71% associated with a stage 2 cancer. And this is an extremely important point to acknowledge because the stage of the cancer is the biggest factor that determines whether or not adjuvant chemotherapy is recommended. For most patients with stage 2 cancer, we generally have not recommended adjuvant chemotherapy. For most patients with stage 3 cancer, we generally do recommend adjuvant chemotherapy. And so it's a hope among all of us that the future, instead of just being stage 1, 2, or 3 cancer, it could be stage 1, 2, or 3 plus or minus whether they have positive circulating tumor DNA. And it could be the future that rather than recommending chemotherapy based off of potential risk factors for patients who aren't actually you, that we could recommend adjuvant chemotherapy on the basis of whether or not the circulating tumor DNA is positive, or even hopefully omit chemotherapy when the circulating tumor DNA is negative. So the conclusion to this background section before we jump into some cases is that, in my opinion, circulating tumor DNA is the best tool available in 2024 to help determine the risk of cancer recurrence following surgery for stage 2 and stage 3 colon cancer. In my opinion, this is the best tool available in 2024 to help you decide if you should undergo chemotherapy for a stage 2 cancer and possibly for a stage 3 cancer, although We still remain to see some evidence on this. And in the next 15 minutes, I'm going to show you some cases where this has been particularly helpful for my patients and I. So jumping into the cases, I'll just say that the demographics and the details of all these cases have been altered to protect patient confidentiality, but the heart of what happened in the encounter remains, and the importance of using the Signatera assay is honest and truthful here. So starting off with a case of stage 2 colon cancer, I'll show you an example of where Signatera helped to inform and reinforce decision-making. So this is a patient of mine who was 20 years old and presented with bright red blood per rectum. This patient was found to have a sigmoid cancer and underwent a sigmoid resection. The pathology showed that this was a stage 2 cancer. It was a T3N0 tumor. And very importantly, this tumor had deficient mismatch repair proteins. In other words, this was an MSI high tumor. And why that's important is because we know that there's very strong evidence that patients who have MSI high stage 2 cancers generally do not derive any benefit from adjuvant chemotherapy because their prognoses are already so excellent. The finding of a deficient MMR or MSI high status in stage 2 cancer is the most important factor to tell us we should not recommend adjuvant chemotherapy to this patient. We then go look through the other potential factors in the pathology to look for any features that could be interpreted as being high risk. And highlighted in red here, you can see that this patient did have one high risk factor, which is that there was LVI, which is lymphovascular invasion. However, on balance, because this patient has a stage 2 cancer, because it is deficient in the mismatch repair proteins, according to all international clinical practice guidelines, it would be recommended that this patient not be offered adjuvant chemotherapy because their prognosis is already so excellent that it is extraordinarily unlikely that adjuvant chemotherapy could provide any meaningful benefit. So I recommended no adjuvant chemotherapy, and the patient and her family agreed. But as you can imagine, this is a 20-year-old patient. She and her family were very anxious about the diagnosis of colon cancer, as anyone would be, and they wanted to gather as much information as possible to help them know, was it the right decision to not take chemotherapy? So we talked about the Signatera tumor assay, and lo and behold, her post-op Signatera assay was negative. And this provided reassurance to both the patient, her family, and frankly myself, that we were making the right decisions. We were using the guidelines, which is still very important. We're using all the available clinical information, which remains incredibly important. And this was just an added, very powerful tool to help us be even more reassured about our decision. So moving into another case of stage 2 colon cancer, I'm going to show you another instance where this helped reassure the patient and myself as the oncologist, although it didn't necessarily impact treatment decision making. So this was a case of a 40-year-old gentleman who presented with abdominal pain. They were found to have a transverse colon cancer and they underwent a colectomy. Like the previous patient, they were also found to have a stage 2 colon cancer, a T3N0. And like the previous patient, they also had LVI present, that lymphovascular invasion, which makes this a quote-unquote high-risk stage 2 colon cancer. Unlike the other patient, this was a microsatellite stable tumor, so it did not have that MSI high status. Even so, with just the presence of one high-risk feature for stage 2 colon cancer, most oncologists around the world would not recommend adjuvant chemotherapy because in this setting, there is actually no good evidence that using chemotherapy provides a significant survival advantage. So I had an informed discussion with the patient. I used some of the previously discussed tools, and I said, we could use chemotherapy, but it wouldn't be my recommendation because I do not think that it would materially increase the chance of survival. However, no decision in oncology should be based just off of what the oncologist recommends. It needs to be about a discussion back and forth and take into consideration the patient's values and preferences and their fears and their hopes. And the patient was very educated and was very clearly able to say, I understand what you're saying. I understand that the chemotherapy does not have a lot of evidence, but if this cancer were to come back, I'll never forgive myself for not doing chemotherapy, even if it would just have a tiny, tiny, tiny benefit. And I'm willing to take the risks of chemotherapy in that regard. And so the patient made an informed decision, and I was very much happy to support it. We talked about using Signatera, and again, the patient was very clear that regardless of the result, it wouldn't change his mind, but he was very keen to do it, again, for the added information that it could provide to help alleviate any anxiety and any worry. So the patient at baseline did go ahead and have Signatera done. Thankfully, at baseline, it was negative. And although it's a bit grainy in this picture, you can see that once again, after the patient finished his adjuvant chemotherapy, we repeated the Signatera and it was once again negative. So in this case, the Signatera didn't change the treatment decision-making process for the patient. The patient's mind was already set, but it helped inform the patient and myself and reassure and provide us further immediate reassurance that this patient was very likely to have an excellent outcome and have a very low chance of cancer recurrence. And I think that's a very meaningful result in and of itself. Moving on to stage 3 colon cancer, we're going to show how a case of where Signatera helped to ensure clearance of that minimal molecular residual disease, the MRD, that you heard about. So this again was another 40-year-old patient of mine who presented with abdominal pain, found to have a transverse colon cancer, underwent a subtotal colectomy. Their pathology showed a stage 3 colon cancer. The lymph nodes were positive, making this a stage 3, so it was an N1B tumor. And my recommendation was to start adjuvant chemotherapy as per all international guidelines, and the patient agreed. And so we discussed as well about the use of adding Signatera to see if it could provide us with some more information. But this was not going to alter our decision to start on the 3 months of adjuvant chemotherapy. So we did draw the first Signatera test post-operatively. And again, it's grainy here, but you can see on the Signatera figures when it's a colored in black circle, that means it's positive. So this patient had a positive Signatera test post-op, which is really interesting because the CT scans, the blood work, including the CEA, all were negative. The only thing that suggested that there could be some residual cancer cells was the Signatera test. The patient completed their 3 months of adjuvant CAPOX chemotherapy, and we repeated the Signatera test, and thankfully it was negative after the fact. So going back to what you heard previously, this patient had clearance of the Signatera test, and so this portends a much, much better prognosis. And another really helpful thing about this is many of you in the audience maybe previously have received adjuvant chemotherapy with your oncologist, and at the end of it, you're done, and you say, well, how do we know if it works? And the doctor has no good way to tell you, and we have to say, and I've had to say this myself many times, unfortunately, the only way we're going to know if it works is if the cancer doesn't come back in 5 years, which is a very unsatisfying thing to say as an oncologist and an even more unsatisfying thing to hear as a patient. For a patient, if you can be told, listen, the Signatera test was negative, it was positive, we did our chemotherapy, now it's negative, that's real-time actionable information that all that trouble and the pain that you went through for 3 months was actually worth it for something. So I think that's a huge positive of this test. And finally, moving to the stage 4 setting. So in stage 4, advanced disease, the mainstay of treatment are palliative systemic therapies such as chemotherapy, targeted therapy, and immunotherapy. These therapies aim to improve how long and how well our patients live. Now, as part of that, because when we have advanced disease, unfortunately, most patients are not cured of their cancer, treatment breaks are an important part of the treatment strategy to allow patients to spend meaningful time away from the cancer center and to regain their quality of life. And tumor-informed circulating tumor DNA may be helpful to inform treatment decision-making in this setting. So let's talk about a case where Signatera helped one of my patients and determining when to take a treatment break. So this was a 65-year-old patient who was diagnosed with a left-sided colon cancer who had disease metastatic throughout the liver. They started treatment with first-line FOLFIRI and panitumumab with an initial good response in the liver, but not enough to allow curative intent surgery. They therefore enrolled in our hepatic arterial infusion pump program at Sunnybrook. Shout out for anyone who is interested. We're always keen to meet more patients and to work together to improve outcomes. They came, they underwent a low anterior resection and had implantation of the hepatic arterial infusion device. They were treated with this special type of chemotherapy we use through the hepatic arterial infusion pump called FUDR, along with their systemic FOLFIRI and their panitumumab. They then had follow-up CT scans about 6 months after therapy, which showed that most of the liver lesions were gone. There were a few liver lesions that were remaining, but it was indeterminate if these just represented scar tissue or there was active residual disease. The patient went on to have a PET scan, and PETs have lots of limitations that we don't have time to address today. But within those limitations, there was no evidence of metabolically active disease. And so we discussed this might be a good opportunity to go after the Signatera assay to see if there was any molecularly detectable residual disease. And very interestingly, when we did this patient's assay, it was negative for Signatera. So there was no residual detectable disease. So how do we interpret this? Well, in the absolute best case scenario, it would be that the patient's cancer had been completely eradicated by the hepatic arterial infusion pump in combination with systemic therapy, and they could hopefully be cured of their cancer. That is an outcome that we have seen in patients on our hepatic arterial infusion pump program. The second best outcome would be that we've just killed so many cancer cells that we've brought the tumor level down to a point where it can no longer be detected by this very sensitive assay, which again is a very good prognostic sign, and hopefully it would mean that it would be a very long time before this cancer would come back and a very long time before this patient would need to go back on treatments again in the future. So both good outcomes. So in conclusion, tumor-informed circulating tumor DNA is an important tool in the management of colorectal cancer. Tumor-informed circulating tumor DNA can help facilitate shared decision-making between the oncologist and their patients, help patients feel more confident in their treatment choices, help us understand whether our treatments have been effective or not, and help guide how to adapt, time, and change our treatments. Right now, cost is the major barrier for most, and as I mentioned at the outset, I'm hoping we can bring down the cost and bring up the accessibility. And with that, I will thank you for your kind attention. It has been my sincere pleasure, and I'm very happy to take any questions, and I will hand it back to Barry.
Well, thank you very much to both of you. I'd like to thank both our panelists, Dr. Liu and Dr. Raphael, for your very informative presentations, and especially for providing us with the latest of data on the test and providing a better understanding of the usefulness of the test in the context of shared decision-making with patients. I really enjoyed that part especially. Before jumping into the question period, if anyone would like to have additional information on the Signatera test, please scan the QR code that will be posted at the end of the webinar, or go to natera.com, that's natera.com/Signatera-CRC, that's SIGNATERA-CRC. I'm sure you'll find that if you just go to natera.com as well. If the test is appropriate for you, it can be ordered through LifeLabs in Canada, and for Ontario and BC residents, Signatera can be ordered online from the website at lifelabsgenetics.com. For non-Ontario or British Columbia residents, Signatera can be ordered by calling 1-844-363-4357 or by emailing ask.genetics@lifelabs.com, and we'll provide that information again at the end of the webinar. So for now, let's take some of your questions.